Hi guys, this is Preeti and you're watching my solution. In this video, I'll be teaching another important question from the university point of view, that is cardiac output. Cardiac output, the sub questions asked under the cardiac output are definition, formula, normal value, measurement of cardiac output, different methods, and then factors affecting the cardiac output and the regulation of the cardiac output. Definition is the amount of blood ejected by each ventricle per minute. Amount of blood ejected by each ventricle, amount of blood ejected by each ventricle in 1 minute we call as a cardiac output, whereas in one single beat is a stroke volume. So the formula for cardiac output is stroke volume into heart rate. How many times the heart beats in 1 minute is the heart rate, and the stroke volume is the amount of blood ejected by each ventricle, same each ventricle in one beat. So number of beats into stroke volume will get the cardiac output. The formula for cardiac output will be equal to stroke volume into heart rate. Average heart rate is 72 beats per minute, and the stroke volume in one single beat, the amount ejected is 70 ml. So if we multiply those two, we'll get the value of cardiac output, that is 40 milliliter per minute. If you have to convert this milliliter into liter, that is 5 liters per minute. In 1 minute, 5 liters of blood is pumped by each ventricle. This is known as cardiac output. For normal values, the weight of the person may varies, and the average blood in in a person may vary, and so stroke volume varies and heart rate varies. It may ranges from 5 liters to 6 liters per minute. If we consider the total body weight as 100%, 8% of the blood is ejected. 8% of the body weight is ejected, like that much of blood is ejected by each ventricle in minute. The measurement of this cardiac output is, there are two types of major types, that is direct and indirect. Direct is usually not practiced because it is done only in experimental animals, and the patients with a open heart surgery we can measure directly. We have to place that instrument on the heart and then measure, so we cannot measure practically. This is not possible, only done in the experimental animals and the patients with open heart surgery. And indirect methods, there are so many indirect methods, like fixed method, direct indicator dilution method, thermodilution method, bacillocardiography, and then echocardiography, pulse pressure method. These are the indirect method which we need not to discuss this. This is not important. Fixed method, only fixed method which is important, and separately they'll ask this question, so we'll discuss fixed method in this video. The fixed method, we have to discuss the definition or principle. Principle is amount of substances taken by an organ will be per minute, per unit time, or per unit time we can take as a minute hour. That will be equal to AV difference of the substances. If we consider this as oxygen, arterial oxygen concentration minus venous oxygen concentration into blood flow, rate of blood flow is the amount of substances that is taken by this organ. The principle will be amount of substances taken by the organ will be AV difference of that substances into blood flow rate. So the formula for the output by each ventricle will be oxygen consumption, that is oxygen consumption means AV difference of this divided by oxygen consumption of this thing will be equal to AV difference if we have cross multiply this, and outflow by each ventricle, that is blood flow. We'll get this formula. The advantages of this method is it measures accurately. We will get the value which is most accurate, and no chemicals are injected, as we inject only this oxygen is only carried, so we need not to inject any chemicals. These two are the advantages of this fixed method, whereas the disadvantages as wish to be, the disadvantages of using this fixed method will be there should be catheterization. So this is done by the experts or physicians, and hospitalization is required to do this catheterization. They have to admitted in the hospital, and it is difficult to measure the cardiac output when the patients are in ambulance or during exercise. If they are doing exercise, it is difficult to measure for them. And the factors affecting cardiac output will be, the formula for cardiac output is a stroke volume into heart rate. The factors affecting the stroke volume and heart rate also affects the cardiac output. If a stroke volume increases or the heart rate increases, cardiac output also increases. The factors affecting the stroke volume will be further, the three factors will affect the stroke volume, that is preload, afterload, and myocardial contractibility, how much it can contract. If it contracts more, it pushes more blood out, and then venous return will always also increases, and the cardiac output also increases. Afterload is nothing but peripheral resistance. If the resistance is more, then the cardiac output will be less. It cannot more blood cannot be pumped out as the resistance is more, and the preload will be the end diastolic volume. The end diastolic volume is more than if preload is more, then cardiac output will be more. Again, preload is affected by the three factors, that is venous return, atrial pump, and ventricular compliance. Venous return is the amount of blood that is returned into the right atrium, and that is venous return. And the atrial pump, how much blood that can be pumped from the atrium to the ventricle is the atrial pump. And ventricular compliance, the amount of blood that is pumped by atrial pump should be accommodated in the ventricles. Ventricular compliance means how much it can expand. The ventricles can expand is a ventricular compliance. Again, venous return is depends on skeletal muscle pump. As you know that soleus muscle acts as a peripheral art. There will be valves in between those, and it pumps the, if we take this as a muscle which is in the lower extremity, it has two valves, upper valve and lower valve. The blood flows through this, and then this muscle contracts and then pushes the blood up, so the venous return increases in skeletal muscle pump. And thoracic pump, if the internal thoracic pressure is negative, then blood flows from the abdomen to the thorax, so venous return increases. Abdominal pump in intra-abdominal pressure should be positive or maximum, so that blood returns into the thorax where it enters the heart. And ECF, during pregnancy, cardiac output increases as ECF volume increase, plasma volume has increased. So during pregnancies and all, ECF volume increases, so further increase in the cardiac output. And then sympathetic activity, during sympathetic activity, cardiac output increases as a heart rate increases in sympathetic activity, cardiac output also increases. Right atrial pressure, it also depends upon the right atrial pressure. If the pressure in the right atrium is more, ventricular filling will be facilitated, so it increases the cardiac output. Factors affecting the heart rate also influences the cardiac output. So if in the sympathetic activity, heart rate is more, so cardiac output will be more. And in parasympathetic activity, during the parasympathetic activity, that is vagal activity, heart rate will be less, so the cardiac output will be less. And regulation of cardiac output by the intrinsic regulation and extrinsic regulation, this is separately asked for a 3-mark question. During the intrinsic intrinsic regulation, there are further two types of regulation, that is Frank-Starling mechanism and rate induced regulation. In Frank-Starling mechanism, ventricular muscle length, force of contraction is directly proportional to the initial length of the ventricular muscle length. So if muscle length is more, filling will be more, so end diastolic volume will be more, it can expand more, so ventricular contraction will also be more. This is said by the Frank-Starling mechanism. It changes the ventricular muscle length, so there is a change in the ventricular muscle length, so which further changes the cardiac output. So this is a heterometric. Metric is a measurement, length, that is length. Hetero means change, there is a change, difference in the ventricular muscle length. So this is a heterometric auto regulation of the heart itself regulates this thing. So this mechanism is also known as heterometric auto regulation of the heart. And rate induced regulation says that frequency of contraction is directly proportional to the force of the contraction. If the frequency increases, force of contraction also increases. In extrinsic regulation, that is regulated by outside factors, this inside the heart itself regulates. In extrinsic regulation, other factors will regulate. Afterload is means peripheral resistance, which is resistance is more, cardiac output will be less, so this is inversely proportional to the cardiac output. Mainly depends upon the peripheral resistance. There is a change in the cardiac output without change in the length, so this is known as homometric regulation of the cardiac output. And hormonal regulation, insulin, which is a ionotropic hormone, it increases the heart rate and further increases the cardiac output. And growth hormone, which increases the myocardial contractility. Myocardial contractility is also a factor which on which stroke volume depends, so further increase in the cardiac output. And neuronal regulation, sympathetic and parasympathetic. Sympathetic increases cardiac output, parasympathetic decreases the cardiac output. If you like my video, the formula for cardiac output is the stroke volume into heart rate, so it depends more on both these factors. Again, heart rate is depend on sympathetic activity or parasympathetic activity, which is vagal activity. Vagal activity decreases the heart rate, sympathetic activity increases the heart rate. And stroke volume further divides depends on the three factors, that is end diastolic volume, peripheral resistance or afterload, end diastolic volume or preload. This is a preload. And myocardial contractility. Myocardial contractility depends upon sympathetic activity, ventricular muscle mass, how much it can pump, and the peripheral resistance depends upon the diameter of the blood vessels. If the diameter of the blood vessels is more, peripheral resistance will be less, and viscosity of the fluid, if viscosity is more resistance will be there. And then end diastolic volume depends upon the atrial pump, ventricular filling, atrium should pump and ventricle should fill, and increase in the venous return will increase the cardiac output. This is a flowchart which shows the summary of the cardiac output, the factors on which the cardiac output depends. If you like my video, please do like, share and subscribe to my channel.